the first question, general pediatrics, we are going to start. Right? We all know growth and development is very important for your all exams, right? Be it INI, be it NEET PG, be it FMG, and amongst this growth and development, this growth curves, also known as human growth curves, also known as Scammon curves. These are also known as Scammon curves. Very important, right? So I have yes, Scammon curves, Dhanush. These curves, I have 4 curves in front of me. Let's look at each of them. Look at the curve A. In this curve A, I can see that in the initial 2 years of life, the growth is rapid, very rapid. 90% of the growth is happening in this phase only. And after that, there is little to no growth. What is this? This is the curve for neural growth. Neural growth. Remember, Horlicks की ad में क्या बोलते हैं कि बच्चे के दिमाग का विकास पहले 2 सालों में सबसे तेज होता है. वो सही बोलते हैं. 2 साल में सबसे ज्यादा बच्चे का न्यूरल ग्रोथ होता है, उसके बाद लिटिल टू नो होता है ना. सो दिस इज न्यूरल ग्रोथ कर्व. न्यूरल ग्रोथ कर्व, राइट. नाउ लेट्स लुक एट कर्व बी. कर्व बी में क्या हो रहा है? इनिशियली बहुत रैपिड ग्रोथ हो रही है, फिर उसके बाद अब प्लाट्यू जैसा है, फिर उसके बाद दोबारा से 10 to 12 ईयर्स ऑफ एज पे दोबारा से रैपिड ग्रोथ हो रही है. ये क्या है? दिस इज ऑल्सो नोन एज सिग्मोइड शेप कर्व. सिग्मोइड शेप और एस शेप कर्व. ये सिग्मोइड शेप्ड और एस शेप्ड कर्व किसके लिए है? मेरी बॉडीली ग्रोथ के लिए है. सो दिस रिप्रेजेंट्स माय सोमैटिक ग्रोथ. सोमैटिक ग्रोथ, right? S for sigmoid, S for S-shaped, S for somatic, right? Then we have C. Look at the C. What is happening over here? Little to no growth in the initial 10 to 12 years, and then there is rapid growth. What is this? जैसे 10 to 12 years हुए, puberty hit की, sexual growth curve. This is sexual growth curve or gonadal growth, you can say, right? And lastly, कर्व डी, जिसमें आपको दिख रहा है 4 to 8 ईयर्स के बीच में एक पीक है. दिस इज फॉर लिम्फॉइड ग्रोथ. दिस इज फॉर लिम्फॉइड ग्रोथ. सो वेरी इंपॉर्टेंट 4 स्कैमन कर्व्स. Yes, Dhanush is right. First is for the neural growth, second is for the somatic, then for the gonads, and then for the lymphoid growth. Dharmesh is also correct, right? So these Scammon curves or human growth curves are very important. Don't forget to revise before the exams. So now let's start with the normal growth pattern. So when we are talking about the normal growth pattern, you should know what is the average birth weight in India, what happens just after birth, how the weight grows thereafter, because once you know the normal things, then only you can tell the abnormal things. So let's start with the normal things first, right? What is the average birth weight in India? Can you tell me what is the average birth weight of a term baby in India? What is that? Can you tell me? What is the average birth weight of a term child in India? It's 3 kgs. And you are right, Dhanush, there is physiological weight loss. Just after birth, the baby does not gain weight. In fact, the baby loses weight. How much the baby loses? The baby loses up to 10% of the body weight, and this happens in the first 7 days of life. This happens in all the babies. That's why it is known as physiological weight loss, right? And this weight that is lost is further regained by day 10. So this is regained by day 10 of life, by day 10 of life, right? Now, how does the weight increases after birth? So let's say the birth weight of the child was X, it doubles. It becomes 2x at 5 months of age. Then it becomes 3x at 1 year of age, 4x at 4 years of age. Then it becomes 5x at 3 years of age, 6x at 5 years, and then 7x at 7 years of age. So if someone asks you, when does the weight double? 5 months. When does the weight triples? 1 year. When does the weight quadruples? 2 years, right? So it is a ready reckoner for you. So, and if someone around you also asks if their baby's weight is fine or not, just ask them their birth weight and you can have a rough idea whether they're going towards a good trajectory or not, right? This was about weight. Now let's talk about the length. Average birth weight was 3 kg. What about the average length? Average length of a term baby at birth is 50 centimeter. And how does this grows? Remember, from birth till 1 year of life, there is gain in 25 centimeter. So by the end of 1 year, baby's length would be 75 centimeter. Then again, in the next 1 year, there is gain of 10 to 15 centimeters. So by the end of 2 years, baby's length is going to be 85 to 90 centimeters. Right? Right. And by the end of 3 years, what would be the height? What would be the height? It said that after 2 years of age, there is increase in 6 centimeters per year till puberty. After puberty, after that, puberty, males can grow up till 10 centimeters per year and females grow up till 8 centimeters per year. Right? So by the end of 3 years, what would be the resultant length? It would be around 96 centimeter or 97 centimeters. Right? So now I have some questions for you. Weight doubles by, we discussed weight doubles by how many months? Yes, yes, weight doubles by 5 months and triples by 1 year. Similarly, they ask when does the height double? Remember, the height doubles by 4 years of age and triples by 12 years of age. Another favorite question of INI people, a child is half of the adult height by what time? So what is the average adult height? Average adult height, we take it as 160 centimeters. So half of that would be around 80 centimeter. We discussed that by the end of 2 years, it's 85 to 90. So around 1.5 to 2 years, the child would be half of the adult height. So the good answer over here is going to be 18 months. 18 months to 24 months. The child is going to be half of the adult height, right? Now after weight and length, now let's move to another favorite topic, that is head circumference. So again, what is the average head circumference for term child at birth? It's somewhere around 33 to 35 centimeter. And how does it grows? A very unique pattern. In the first 3 months of life, how does it grows? It grows 2 centimeters per month. 2 centimeters per month. Then in the next 3 months, that is 3 months of the age till 6 months of the age, it's 1 centimeters per month. And thereafter from 6 months to 12 months, it's 0.5 centimeters per month. 0.5 centimeters per month. So let's see how much the head circumference will grow. 2 centimeter per month means 2 into 3, that means 6 centimeter. Right? So in the first 3 months, 6 centimeters gain would be there. Then in the next 3 months, 1 into 3, that is 3 centimeters. And thereafter 0.5 into 6, that is again 3 centimeters. So 6 plus 3 plus 3, that is total 12 centimeter gain would be there in the first year of life, right? If I ask you at birth, what percentage of the head size is that, how much percentage of the head size does the child have when we compare to the adult head circumference? So remember, at birth, baby's head size is actually 60% of the adult head circumference, and it becomes 90% by 2 years of age. 2 years of age, right? Neural growth, remember, by 2 years of age, it's going to be 90% growth happening. Right? So by 2 years, this is achieved. Okay, so this is all about the head circumference. Now, a very small topic, periods of growth. Here we are going to discuss some of the entities. In pediatrics, no neonate is similar to an infant. No infant is similar to a toddler, right? So we have different age group and different names for different age groups. We start with antenatal period. That means before the birth of the child, when the child is in the womb of the mother. So when there is fertilization of the ovum and zygote is formed, we label that product of conception as fertilized ovum or zygote till 2 weeks, right? From 0 to 2 weeks, it is called fertilized ovum. Then after 2 weeks, that is 3 weeks to 8 weeks onwards, it's embryo. Then 9 weeks onwards, 9 weeks till birth, it is fetus. So how to remember? Remember, E for embryo, E for 8. Right? And for fetus, if I make a mirror image of F, it becomes like this, and I join it and become a 9. Right? So embryo 8 and fetus 9. Then we have a period, perinatal period, that includes some part of the antenatal period and some part of the postnatal period. So perinatal period starts from 22 weeks of gestation till 7 days of life. 7 days of life. right? So this is perinatal period. Now let's start with the postnatal period, that is just after the birth. So just after the birth, the baby is called a neonate. This neonatal period is from 0 days to 28 days of life. Early neonatal period is the first 7 days, and thereafter we have late neonatal period. Till 1 year of age, this child is going to be called as infant. So if I say every neonate is an infant, that's true. But if I say every infant is a neonate, that's false, right? So in between period of a neonate and the umbrella term of infant is known as post-neonate. So post-neonate starts from 28 days of life till 1 year of age. That's post-neonate. Then comes a toddler. What is a toddler? 1 to 3 years of age. T for 3, T for toddler, right? Then comes preschool, 3 to 6 years. Then school going, 6 to 12 years. Remember, S for school, S for 6. So this is school going child. Now then starts postnatal adolescent phase. This adolescent period is from 10 years to 20 years. 10 to 20. It is further divided into early adolescent, mid adolescent, and late adolescent. Early is 10 to 13, mid is 14 to 16, and then late is 17 to 20 years of age, right? So this is all about the periods of growth. No doubt till now, right? Dhanush, Dharmesh, both are amazingly answering each and every question. Very good. I hope you're on the right track of the revision. Now let's start with the assessment of growth. So when we talk about assessment of growth, we have certain factors that are dependent on the age and certain factors that are independent on the age. The things that we have discussed till now, weight, length, head circumference, all of these are age dependent. Why they're age dependent? If I say 3 kg of a newborn, that sounds right? But if I say 3 kg of a 1-year-old child, that doesn't sound right? So this weight factor is an age dependent factor. Same goes for length, same goes for head circumference. So the 3 parameters, age dependent parameters that we have discussed are weight, we have length, we have head circumference, right? Now we have certain age independent factors too. What are these age independent factors? We have 2 age independent factors. We have mid upper arm circumference and skin fold thickness. Here age won't be a factor. Now let's understand these. Firstly, we are going to see some of the instruments for the age dependent factors, and then we will move on to age independent factors. So weight we have already discussed. We have 2 instruments over here. See this one instrument, we have certain a scale like thing and a jhola in which the child is lying down. What is this device known as that we use to measure weight? Remember this S-shaped hook over this jhola? This S-shaped hook tell me that this is S spring, right? This is spring balance. So remember, this is spring balance. And then we have this scale where the child will lie down. This is known as beam balance. This can be electronic also. This can be this manual type also, right? Ancient type also, not electronic, non-electronic beam balance also, right? Now let's move to length and height. What is the difference? Look at this image. Here, I'm measuring the length of the baby by making the child lie down using a device whose head end is fixed and foot end is mobile. I will move this foot end to rest on the foot of the baby and take the length. On the other hand, look at this device. I'm making this girl stand straight and then noticing the height, recording the height. So what is device A? What is device B? By device A, I am measuring the length, and this device is known as infantometer. The name says infant, so you might think that I am going to use this for an infant that is less than 1 year of age, but no, we take length till 2 years of age. Why 2 years of age? By 1 year the child can stand. I can take the height through the stadiometer, but why I am using this infantometer till 2 years? Because there is physiological bowing of legs. Till 2 years. So if there is physiological bowing and I make the child stand like this, the height recorded would be less than the actual height. Here I'm actually, I'm making the child lie down, I'm actually straightening the legs and taking the length, right? So Remember, till 2 years of age, you're going to take length by using this device, that is infantometer. And after that, after 2 years of age, you're going to take height by this device, which is known as stadiometer. Stadiometer, right? So with that, now let's move to age-independent parameters like mid-upper arm circumference. So why mid-upper arm circumference is an age-independent parameter? What happens in the age group 6 months to 5 years of age? In this age group, what happens? Initially, the child is very chubby, has a lot of fat. And after that, after 6 months of age, the child now will start moving, crawling here and there. So eventually this fat gets reduced and muscle increases. So if I take the mid upper arm circumference, how do I measure this mid upper arm circumference? I take these two bony points, I take the acromion process above and olecranon process below. I draw a line joining these two, and at that midpoint I'm going to measure the mid upper arm circumference. So initially it is made up of mainly fat, and then fat reduces and muscle increases. So overall circumference will stay somewhat constant in this age group, right? That's why it is an age independent parameter. So 6 months to 5 years, I can employ this mid upper arm circumference. To measure this for community screening of this malnutrition, we use this concept, right? Can you see this colorful tape? What is this colorful tape called? This colorful tape is known as Shakir's tape. We use this for community screening of malnutrition. How do we use this? Can you see in this colorful tape, we have a red zone, we have a yellow zone, we have a green zone. So what is this red zone? This red zone is less than 11.5 centimeters. Then we have yellow zone 11.5 to 12.5 centimeters. And then we have green zone that is above 12.5 centimeters, right? So we have this mid upper arm circumference. So this red zone, which is less than 11.5, denotes that my child is severely malnourished. This tells me that the child has malnutrition, and above 12.5 means the child has normal nutrition. Right, so this is all about mid upper arm circumference. Now let's move to the next age independent parameter, that is skin fold thickness. So again, skin fold thickness is an age dependent thing. In skin fold thickness, we are actually grabbing a part of the skin using this device. What is this device called? This is calipers. Which caliper? Harpenden caliper. So we use this caliper to measure the skin fold thickness. We are actually pinching the skin within this device, right? We can take areas like triceps area, your subscapular area, your interscapular region. In all of these regions, you can make a pinch of the skin and measure the thickness. The most common site that we use is triceps. And apart from that, other sites that we can use include scapular region, infrascapular region, interscapular region. And if it is less than 6 mm, the child has severe malnutrition. And above 10 mm, it is considered as normal nutrition. Right, apart from the, this completes my age independent parameters. Now let's move to the next segment, that is puberty and adolescence. So what is puberty and what is adolescence? Adolescence we have just discussed, right? Adolescent is nothing but an age group 10 to 20 years of age. What is puberty? Puberty means appearance of secondary sexual characters. So what the examiner asks here? The examiner asks, what is the sequence of puberty? How the sexual changes are going to appear? So remember, in both males and females, the mnemonic to remember the sequence of puberty is TPM. In females, T, thelarche, that is appearance of the breast tissue, thelarche. Then we have P for pubarche, appearance of the pubic hair. And lastly, we have menarche, onset of menses. Right? Similarly, for males, how the males TPM is said? T is here testicular enlargement, right? So firstly there is testicular enlargement. Then we have penile enlargement, that is penile growth, and pubarche, and thereafter there is manly. What do I mean by manly? That means the child will show all the manly features like beard appearance, deepening of the voice, all of those manly things. Okay, so this was all about the sequence of puberty. Now when we are discussing puberty, a very important grading here is important. What is that important grading? My Tanner staging. Before Tanner staging, let's discuss some of the MCQs that they ask. So first MCQ, they ask, what is the biochemical evidence, first biochemical evidence of puberty? Remember, the first biochemical evidence of puberty is GnRH pulse. GnRH pulse. But if they ask what is the best marker of puberty, then you have two options, LH and FSH. Prefer LH over FSH, right? Then comes the staging for assessment of puberty that we are going to discuss. What's that? That is sexual maturity rating or Tanner staging. Sexual maturity rating or Tanner staging. Then they ask, when does the growth spurt happen in females and when does this growth spurt happen in males? So remember, in females, this growth spurt is going to happen earlier. When earlier? In this SMR stage 3. In SMR stage 3, female growth spurt is going to happen. And what about males? In males, it happens in stage 4. Stage 4. Right? Now, one by one, now let's discuss this SMR staging. Firstly, we are going to discuss the male staging. Very easy to remember. Look at this. So remember, stage 1 and 5 is very easy to remember. 1 is going to be a pre-adolescent stage or pre-pubertal stage, and 5 is going to be adult-like. Right? So first is my pre-pubertal appearance. Pre-pubertal in case of male means the testicular volume would be less than 4 ml. Once it reaches the 4 ml, we can say that the secondary sexual characters, the growth has started, growth has begun. So here the testicular volume is going to be less than 4 ml. 4 ml. Right? Then comes stage 2. In stage 2 now there will be increase in the testicular volume. It becomes 4 ml, above 4 ml. And also, can you notice over here, very sparse pubic hairs have started to come. So here you notice sparse pubic hair. Then in stage 3, now the pubic hair, can you see, are coarsening. So there is coarsening and curling of the pubic hair. And also there is increase in the penile length. Thereafter, we all know in stage 4, growth spurt is going to happen and there is increase in the penile girth now. And with staging, you can definitely appreciate that the pubic hair are coarsening, curling. Here in stage 4, everything is almost like the adult. But the only difference is that now in stage 5, these pubic hair will be present on the medial thigh as well, right? So remember, in stage 5, now the pubic hair would be on the medial thigh. And what is the volume, testicular volume, adult volume? That is 25 ml. So these are the important points, important MCQ points that they ask in the exam. Okay, so stage 1 is going to be prepubertal, testicular volume less than 4. Stage 5 is going to be adult, where the pubic hair are present on the medial thigh as well. Testicular volume is going to be 25 ml. Another question that they ask is, when does scrotal reddening happens and when does scrotal darkening happens? So remember, scrotal reddening happens in stage 2. So in stage 2, you will see scrotal reddening. And what would you see in stage 4? In stage 4, you see scrotal darkening. Right? So this is all about the Tanner staging in males. Now let's go to females. Look at this. Here we are seeing two things. Firstly, the appearance of the breast, and second is the pubic hair. So first and 5 would be similar. First is prepubertal. What about 5? 5 would be adult-like, where you see pubic hair on the medial thigh as well. Now let's talk about stage 2. Can you see in stage 2, now the breast bud has appeared. So there is appearance of breast bud and very sparse pubic hair, very sparse pubic hair. In stage 3, we all know growth spurt happens, and again the pubic hair becomes coarsen and start to curl. In stage 4, everything is like adult, except there is no hair on the medial thigh, not on medial thigh. And in stage 4, there is formation of secondary mount. Secondary mount, right? Secondary mount. So this is all about the Tanner staging in females. We all know growth spurt is going to happen in stage 3. So with that, we finish this segment of growth. Now let's move to a very important section, that is short stature assessment. I told you in the beginning that you need to know the normal things, then only you can tell what is abnormal. So you know what is the normal height, what is the how the height normally grows. So when do you say a child has short stature? We say a child has short stature when the height for age and sex of that child is less than -2 standard deviation or less than third centile. Less than third centile. We all know that the population exists in a bell-shaped curve, right? Some people are going to be short, some people are going to be tall, majority are in the middle. But how do you know that this is a normal variant of the short stature or there is some pathology happening? For that, we calculate this target height. I am short because my parents are short. My genetic potential is such that I am going to stay short. So how do we calculate a target height when the child comes to us? We ask about the mother's height and the father's height. So you calculate this target height, you take the mother's height and the father's height and average it out. If it is a boy child, then you add 6.5 centimeter. If it is a girl child, then you subtract 6.5 centimeter. This is going to give you target height or mid-parental height. This is one of the questions that the examiner is going to throw at you. He is going to give you a scenario of short stature or give you mother's height and father's height and ask you to calculate the target height. Right, so these two important concepts, you should know what is the definition of short stature and what is target height, right? With that, now let's discuss short stature. Firstly, short stature could be either physiological or pathological. Physiological, one thing I have discussed, that I am short because my parents are short. This is familial short stature, that the genetic potential of the child is such that the child is going to be short. So this is familial short stature. Parents will also be short over here. Here the baby's bone growth will collaborate with the actual age of the child. The second entity in the physiological short stature is CDGP. What is CDGP? Constitutional delay in growth and puberty. What do you mean by that? Here what happens, the parents are of normal height but the child is short. When you ask the history of the parents about their puberty, they will say that we were also short in the beginning, but later on in class 9th or 10th, they gained their height and now their final height is within the normal range. So this is nothing but constitution delay in growth and puberty, where you are going to encounter a history of delayed puberty in parents, right? So let's differentiate these two causes of physiological short stature. Firstly, history wise, in constitutional delay in growth and puberty, you are going to have a history of delayed puberty, whereas in familial short stature, you're going to have a history of short stature in parents, short parents. What about the final height? I told you final height in cases of constitutional delay in growth and puberty is of the normal range. This child is not going to be to stay short for long, right? He will eventually catch up the height. But in familial short stature, the final height will also be short. What about puberty over here? The puberty over here is delayed. But on the other hand, in familial short stature, puberty here would be at the normal time. What about the height age? What is height age? Height age means, I told you what is the normal length at the birth. It's nothing but 50 centimeter. At 1 year, it's going to be 75. So 50% of the population, I know average is going to be 75 centimeter at 1 year. So if I randomly tell you that 75 centimeter is the length of the child, what do you think is going to be the age? You will say, ma'am, it is going to be around 1 year of age, right? So height age is nothing but the age at which that particular height is at 50th centile. So here, because the child is short in both of these scenarios, height age is going to be less only. Height age is less. So in both of the scenarios, height age would be less. What about the bone age? Here in constitutional delay in growth and puberty, puberty is delayed, so bone age would also be less. But in familial short stature, bone age is going to be normal. What about the relationship between chronological age, bone age, and height age? See, bone age and height age both are decreased over here. Here, bone age is normal, but height age is less. So compare it to the chronological age. What is chronological age? What is chronological age? Chronological age means the actual age of the child, actual age of the child. So here, bone age is equal to the height age, and both of these are less than chronological age. On the other hand, I know bone age is going to be normal. So here, height age is less than chronological age, but it is equal to the bone age, right? So this is how you're going to make a relationship between these two. Remember, bone age is going to be normal and familial short stature. Right? So with that, we complete the concept of physiological short stature. Now let's move to the disproportionate side of the short stature, pathological short stature. So when we talk about pathological short stature, it could be either proportionate or disproportionate. Proportionate means the child is proportionately small, proportionately short. And disproportionate means either the trunk is short or the limbs are short. For that, we need to assess this ratio. This ratio is very important, upper segment, lower segment ratio. How do we measure this ratio? So we make the child stand like this. Height from the top of the head till pubic symphysis. This is upper segment. And what is lower segment? If you subtract the entire height of this child from the upper segment, the remaining is going to be lower segment. And we take this ratio, upper segment, lower segment ratio. So normal upper segment, lower segment ratio at birth is 1.7 is to 1. 1.7 is to 1, right? The growth is in the cephalocaudal direction. So initially my upper segment is big and lower segment is short. But as the child grows in the cephalocaudal direction, my lower segment is going to increase. If the lower segment is going to increase, my ratio is going to decrease as I age, right? So by 3 years of age, it becomes 1.3 is to 1. By 6 years of age, it becomes 1.1 is to 1. By 10 years, it becomes 1 is to 1. And after 10 years, the adult ratio, that is 0.9 is to 1, or I can also write it as 1 is to 1.1 is achieved. So this normal ratio you should know. If this ratio is not normal, the child has disproportionate short stature. Disproportionate short stature, right? So let's see what are the causes of this disproportionate short stature. Firstly, if in a scenario you see that the upper segment lower segment ratio is increased, what do I mean by that? Let's say take an example of a 3-year-old child. I know at 3 years what should be the upper segment lower segment ratio? It should be 1.3 is to 1. If I say this ratio is 1.6 is to 1, that means this ratio is increased for that particular age. That means my upper segment is big, my lower segment is short. What type of dwarfism is this? This is short limb dwarfism. Short limb dwarfism. And whenever I say short limb dwarfism, think of these three conditions. What are these three conditions? First is rickets. Second is your achondroplasia. And third is congenital hypothyroidism. Congenital hypothyroidism. If I wake you up in the sleep and I ask you what are the three causes of the short-limb dwarfism or increased upper segment lower segment ratio, you should be able to answer me, right? You have three causes: rickets, achondroplasia, and congenital hypothyroidism. Now let's discuss this decreased upper segment lower segment ratio. Decreased upper segment lower segment means my upper segment is short, lower segment is normal. So short upper segment is mainly my trunk. So this is short trunk dwarfism. And we all know what is our trunk made up of. Our trunk is made up of mainly spine and the ribcage. So any problem with the spine, my trunk's growth is going to be affected. So all the conditions where my spine is affected, for example, if the child has some vertebral anomalies, TB spine, that is spot spine, storage disorders like mucopolysaccharidosis, right, and spondyloepiphyseal dysplasia. In all of these conditions, you are going to appreciate short trunk dwarfism. So with that, we cover this important topic of short stature. Now let's move to development section, that is developmental milestones. So remember, in developmental milestone, what is important? These individual terms are indeed important, but very important is that you remember the sequence, so that when you are in the exam, by just ruling out that this thing happens at this age, this thing happens at this age, so the answer should be in between, you should know that sequence is very important, right? So remember, in these developmental milestones, mug up the sequence first. Sequence is important. Right, sequence is important. So let's start with the gross motor milestones first. What is gross motor? That means my gross bodily movement: sitting, standing, holding neck, running, walking. All of these are my gross motor milestones. So firstly, this gross motor milestone, the very first gross motor milestones is the neck control or the head control. This is achieved by 3 months of age. Then after head comes the trunk. So child now tries to sit. So firstly, the child will be sitting with the support, that is in the tripod position, at 6 months of age. Then the child will be sitting without support at 8 months of age. Right? Then the child will try to stand. So the child will stand with the support at 9 months of age. After standing, now the child would be creeping, crawling. So remember, at 8 months, the child starts crawling, and by 10 months, the child will be creeping. And also at 10 months of age, the child will be holding the furniture and walking. So this is known as cruising. Cruising while holding the furniture. Cruising while holding the furniture. At 12 months, that means at the first birthday of the child will be now standing independently and cutting the cake. That means by the age of 12 months, the child will stand without support. But what about walking? When the child has to receive gifts or return gifts, how will the child go? Will the child walk independently? No. The child will now walk with one hand held. So walking with support will be there. Walking with support. Walking without support will happen at 15 months. So by 15 months, the child will be walking without support. Walking without support. And at 18 months, what will happen? When we turn 18, what do? We are adults now. We can run here and there, run away from our homes, right? Similarly, at 18 months of age, the child also runs. So the child will be running at 18 months of age and will be exploring here and there. What will the child will explore? The child will explore the drawers of that home. Exploring drawers. By 2 years of age, now the child can jump and climb the furniture. Jumping, climb with the furniture. By 3 years of age, the child will be driving a 3-tire cycle. What's that? Tricycle. So by 3 years of age, the child will be riding a tricycle. By 4 years of age, the child will be hopping, skipping, but on one foot. Hopping, skipping on one foot. And after that, at 5 years of age, the child will be hopping, skipping on both the feet. right? Like adults, like we do, skipping on both the feet. Right, so this was about the major gross motor milestones. When we talk about gross motor milestones, one important milestone is stairs milestones, right? Going up the stairs, down the stairs. So what happens initially that when the child goes up and down the stairs, the child will be keeping both the feet on one step. Both feet on one step, then both feet on one step. Similarly, when the child is coming down, both feet on one step. Thereafter, the child learns how to keep one feet on each step and go up and down the stairs like we do, right? So firstly, the child learns to do this upstairs and then learns to do this downstairs. Going up is easier than coming down. So remember, firstly, the child goes upstairs and downstairs, both feet on one step. This happens by 2 years of age. Then the child will learn how to keep 1 feet per step. This first the child will learn to go upstairs because that's easier. That happens by 3 years of age, and thereafter downstairs by 4 years of age. Right, so this was about important gross motor milestone. Now let's understand the fine motor milestones. So when we talk about fine motor milestone, what are these milestones? These milestones are the fine movements of my hand, right? Holding objects, making drawings, doing everything from my hands. These are the fine movements, right? So fine movements, initially what happens? The child learns to grasp toys, rattles. So remember, by 3 months, the child's palmar grasp will begin to lose and the child will try to grasp toys and rattle. And by 4 months, the child will be taking those objects into his mouth. So grasping of toys, rattle, and mouthing will happen around this age group. Then by 5 months of age, the child has a bidextrous grasp. Bidextrous grasp, that means the child will be using both the hands to hold the object. And then by 6 months, the child is going to have a unidextrous grasp. Unidextrous grasp. By 9 months, now the child will have pincer grasp. So what is pincer grasp? Child will be holding the object like this, within the thumb and the other fingers. This is pincer grasp. Initially, this is immature pincer grasp. And by 12 months, it becomes mature when the child will be just holding the object like this, right? Okay sign between the thumb and the index finger. This is the mature pincer grasp. So remember, whenever you see this okay like sign like this is mature pincer grasp. This is going to be immature. This is going to be immature grasp. This is immature grasp. When accessory fingers are used, this is immature grasp. Right? So now the child has learned how to hold this pencil. Mature pencil grasp has come. So by 15 months, the child will now be drawing things from this pencil. By 15 months, the child starts to scribble. Thereafter, the child will draw various things. Firstly, 2 years of age. 2 years of the age, child will join these 2 points and make a line. Right? So by 2 years of age, the child will be able to draw this line. By 3 years of age, the child draws this circle. By 4 years of age, the child will draw this plus sign or cross sign. 4.5 years, the child will draw this rectangle. 5 years of age, the child will draw a triangle. Then 7 years, the child will draw a kite-like or diamond-like structure. 9 years, a cylinder. And then a cube at 11 years of age. Right? So this is all about the various drawings of the fine motor skills that are going to happen. When we talk about fine motor, then a very important fine motor skill we use every day. What is that? Dressing, undressing, right? Dressing, undressing is a fine motor skill that we use every day. So when does the child learns to dress and undress? Firstly, understand what is easier, dressing or undressing? We all like undressing, right? So undressing is easier. Firstly, the child learns how to undress himself and then dress himself. Same goes for buttoning. Firstly, the child learns how to unbutton and then button. Okay, so firstly the child would be undressing with help. Then sooner or later the child will learn how to undress and dress without help. Right? So remember, firstly comes undressing with help. This undressing with help comes at 2 years of age. Then comes dressing with help, 3 years of age. Then the child will undress without help at 5 years of age. Then comes buttoning, unbuttoning. Firstly, the child will learn unbuttoning at 3 years of age and then buttoning at 4 years of age. Right? So this is all about the dressing skills. With that, we complete the fine motor milestones. Now let's move to the social milestones. So what are social milestones? How the child interact with others, right? First interaction is with the mother, of course, then with the family members, then the child goes outside, the child is going to play with other peers. So how is this relationship going to happen? So firstly, social, the very first social milestone, that the child gives a social smile. So the child will look around and smile, right? Smile in response to interaction, a social interaction. So the social smile, the first smile that parents notice is at 2 months of age. Then by 3 months, the child realizes that my mother is really important, right? She feeds me, she cares for me. So this 3 months of age, the child will develop a special mother regard. Mother regard, the child will appreciate the mother. Then comes 6 months where the child has mirror play. Now, what happens in mirror play? The child looks himself in the mirror and appreciate himself, right? So, firstly, appreciating the mother, then appreciating himself, mirror play. So, now the child knows who is my mother and who am I, right? So, both the things the child appreciates. So, after the 6 months, the child will now develop a stranger anxiety. Child will develop stranger anxiety. Right, child knows now who is my mother, who am I, anyone else who comes from outside is a stranger, and the child has stranger anxiety, right? And by 9 months, a very important milestone happens. This milestone is object permanence. Object permanence. What is object permanence? So before 9 months, what happens? If you show a toy to the child will play with it. But if you hide it somewhere, the child won't look for it, right? Because whatever is in the vision is only the universe of this child. The child does not have any object permanence. But once this 9 month milestone has happened, then the child realizes if it is not in my vision, does not mean it is not in my universe. It is still in my universe. The child will look for this object here and there, right? So this object permanence will happen. And when this object permanence happens, the child needs to wave bye-bye to some things, right? So here the child learns to wave bye-bye. Bye-bye. Right? If you're in a long distance relationship, this milestone is a very sad milestone, right? You know that your partner is still in the universe but not in front of you, and you unfortunately have to say bye-bye every time they leave, right? So remember, this 9 month milestone is a very important milestone, object permanence. After 12 months, after this 9 months, now all the drama is going to happen. All the drama, I mean, acting will happen. So by 12 months, now the child will be acting. That means the child will do imitation, mimicry, all of these things is going to happen. So by 12 months, the child is going to act, imitate, right? By 18 months, the child will be doing domestic mimicry. That means the child will notice day-to-day functioning that is happening. Maybe your maid or you sweeping the floor, the child will mimic that. Cooking food, the child will mimic that. So domestic mimicry happens at 18 months. By 3 years of age, the child will now be able to tell 3 things. What are the 3 things that the child will be able to tell you? His age, sex, and name. Age, sex, and name. Right? And also by this 3 years, handedness develops. That means the child will be preferentially using one hand. That means either right hand or left hand, right-handed or left-handed. And by 4 years, now the child develops right to left discrimination. Right to left discrimination. That means by the end of 4 years, the child will be able to tell me, this is my right shoe, this is my left shoe, this is right, this is left, right? So this is all about the important social milestones. Important social milestones are also this interaction thing that the child will do now outside. Right? So we discussed that the child developed stranger anxiety around 7 months. What happens by 15 months? 15 months, the child appreciates parents a lot. Right? Firstly, the child will hug the parents. By 18 months, the child will now kiss the parents. Right? You're hugging, kissing the parents, developing such a cute bond, right? So now if the parent is going outside for work, the child will develop intense separation anxiety. So remember, by 18 months, there is going to be separation anxiety. Now, this child cannot stay anxious for long, has to go outside and make new friends. So, by 2 to 2.5 years of age, the child will go out and do parallel play. What is this parallel play? Remember your first day of MBBS, what was happening? You were all sitting in the lecture theatre or maybe dissection hall, and your friend was sitting next to you. You didn't know that this is going to be your friend, and you both were doing your own thing initially, very hesitant to talk to each other, right? So, maybe you were on your phone or you were looking at your notes or your books, and he was looking at his own books and notes. So you both were sitting together but doing things separately, right? So this is parallel play. So two children will be sitting together but they will be playing with themselves only. So this is parallel play. And thereafter, as they grow, by end of 3 years, they are now going to share thoughts, share toys, and play together. This is known as cooperative play. So by 3 years, they are going to have cooperative play. And by 4 years, they will have a whole gang and do gang bang. They will do role play, right? Role play, घर घर जो खेलते हैं ना, so group play, role play they are going to do. So this was all about interaction and playing. With that, now let's move to the last category of the milestones, that is language milestone, where the child will use his vocal abilities to connect, to express himself. So first milestone that we notice is at 2 months of age, the child will produce cooing sounds. So cooing would be there. By 4 months, the child will be laughing out loud. By 6 months, now the child will speak out monosyllables like ma, ba, da. And by 9 months, the child will join these monosyllables and make mama, papa, dada, right? So bisyllables. By 1 year of age, now the child will say his first real word. What do I mean by first real word? So if you ask your mother or your father, what was my first word, mama, papa, they will tell you either it was mama, papa, dada, anything like that, right? But this is not your first real word. You were just joining two monosyllables and making mama, papa, dada sounds. First real word means the word that the child uses and knows the meaning of. That comes at first year of life. That means 12 years. By 15 months, now the vocabulary is of 4 to 6 words. By 18 months, it becomes 8 to 10 words. By the end of 2 years, the child will be using 2 word sentences like give food, give water, pani do, khana do, like 2 word sentences, bahar chalo, like this, right? So by the end of 2 years, remember 2 word sentences the child would be using, 2 word sentences. And when we talk about the vocabulary would be around 50 to 100 words. And now the vocabulary would increase and increase. By 3 years, the child would now be using pronouns like मैं, तुम, आप, I, me, you, all of these pronouns the child will be using, I, me, you. And by 5 years, by 4 years, what is going to happen? 4 years, remember the child will be telling you stories, poems. And how does you start the story? Once upon a time. That means the child knows that past tense is something, right? So child will also be able to tell you about past tense. That means the child will tell कि कल ये हुआ था, वो सारी चीज़ें वो बता पाएंगे. And then comes 5 years of age. In 5 years, the child will now be telling you future tense कि हम कल जाएंगे, कल करेंगे. And will also ask meaning of words. Will also ask meaning of words. So with that, we cover the 4 major domains: gross motor, fine motor, social and language milestone. Now let's talk about the special milestone, that is vision milestone. In this vision milestone, what we are checking? We are checking the visual field of this child, tracking movement of the child. So what do? We take a ring, a red dangling ring, and we keep this red dangling ring 8 to 10 inches away from the child. Right? A newborn can follow this till 45 degrees. 45 degrees, a newborn can follow it. By 1 month, this child can follow up till 90 degree. And by the end of 3 months, the child will be following it 180 degree. Right? Then the examiner asks, when does the binocular vision develop? So this binocular vision is established by 4 months of age. With that, we cover very important segment of growth and development. Now let's move to the next segment, that is micronutrients in health. So I know this is an overlap topic. You must have studied this in biochemistry also, but here we needed a special mention because yet again a very important topic for your INICT exam. So in micronutrients, let's start with vitamins. So we all know what are vitamins? What are vitamins? Vitamins are micronutrients. That means we need little amount of these in our diet. And if we don't get these micronutrients, a variety of deficiency syndromes happen. So we have two types of vitamins, water soluble and fat soluble. What are the water soluble vitamins? We all know B and C, B complex and vitamin C. And what are the fat soluble vitamins? Vitamin A, vitamin D, vitamin E, vitamin K. Right, so one by one we'll discuss each of these and whatever deficiency these vitamins causes. So firstly, let's start with water soluble. We are covering the B complex vitamins first. So in B complex, the first vitamin that we are going to discuss is B1. The other name of B1 we all know is thiamine. What does thiamine deficiency causes? It causes beriberi. It could be dry beriberi or wet beriberi. Dry beriberi, as the name suggests, it affects my nerves, and wet beriberi is going to affect my heart, cardiac tissue. So the child is going to have cardiac failure. And in alcoholics specifically, this vitamin deficiency is noted. And the syndrome, the constellation of symptoms in those alcoholics because of this thiamine deficiency is termed as Wernicke-Korsakoff syndrome. And the mnemonic to remember the triad that is seen in this Wernicke-Korsakoff syndrome is GOA. What is G? G is for global confusion, ophthalmoplasia, and ataxia. So this is Wernicke-Korsakoff syndrome. Now let's move to B2. What is the other name of B2? It's riboflavin, and ribo means red. Remember ribo, red, right? So what happens in riboflavin deficiency? You will see red vessels coming out. So can you see this cornea over here? There is this neovascularization, blood vessels are coming into the cornea. So this is neovascularization of the cornea. Also you see reddening around this angle of mouth, angular ciliitis, glossitis, magenta colored tongue. These all are features that you're going to appreciate in cases of riboflavin deficiency. So remember these markers: magenta colored tongue, neovascularization of cornea. After that, we have B3. B3, other name we all know is niacin. What does niacin deficiency causes? It causes pellagra, right? Pellagra, 3D or 4D diseases. So this pellagra, what is this 3D? 3D, what is this 3D? Diarrhea, dementia, and dermatitis, right? So diarrhea, dementia, and dermatitis. Sometimes a fourth D, that is death, is also included. This is a typical sign that you see in this niacin deficiency or pellagra. What can you notice over here? Can you notice this hyperpigmentation in the skin exposed areas? What is this? This is known as Casal necklace. Casal necklace. This you see in cases of pellagra, right? Niacin deficiency. After B3, there is nothing like B4. We have B5. What is the other name of B5? The other name of B5 is pantothenic acid. Pantothenic acid, right? And how do you wear your pants? Through your foot, right? So pantothenic acid deficiency causes burning foot syndrome. Burning foot syndrome. As the name suggests, burning foot, you see burning sensations in the foot. So that's why it is also known as nutritional melalgia. Nutritional melalgia. Then we have B6. B6, the name is pyridoxine. And what does this pyridoxine deficiency causes? This pyridoxine deficiency causes anemia, as well as a very important cause of neonatal seizures. Neonatal seizures, remember, though it is rare, but when you are seeing the algorithm of neonatal seizures, you have tried first line drugs, second line drugs, third line drugs, and the child is still not responding. Then we give this trial of pyridoxine because this pyridoxine deficiency can also cause neonatal seizures. Then we have B7. What is the name of B7? Biotin. And what does this biotin deficiency causes? It causes alopecia, dermatitis, right? If you are a skincare, hair care enthusiast, especially the girls out there, then biotin supplements is something which is very well advertised, right? So remember, this biotin deficiency causes alopecia, dermatitis. That's why the skincare and the hair care enthusiasts take this biotin supplements, right? After B7, we don't have B8, we have B9. What is B9? B9 is folic acid, folic acid, folic acid, right? Folic acid. So what does this folic acid deficiency causes? Firstly, remember, all the pregnant ladies, they should be taking their folic acid supplementation. Why? Because this folic acid deficiency is very well known to cause neural tube defects in the fetus. So first is neural tube defects, and after birth, megaloblastic anemia, megaloblastic anemia. Then we have B12, that is cobalamin, and we all know it again causes megaloblastic anemia. What else B12 deficiency is known to cause? SACD. What is SACD? Severe subacute combined degeneration. Subacute combined degeneration. Right? So this is all about the B complex vitamins and the deficiency that they cause. Now let's talk about vitamin C. Vitamin C. What is vitamin C? Ascorbic acid. And what is the disease that you see with the deficiency of vitamin C? It's scurvy. Scurvy. Right? It's scurvy. So why the scurvy is happening? Vitamin C is less. Vitamin C is deficient in the diet. Vitamin C is very important in the collagen synthesis step. Very important in the collagen synthesis step. It is important for the hydroxylation of proline and lysine, right? So proline and lysine, very important for the hydroxylation. And when this vitamin C would be deficient, my collagen synthesis would be affected. So this collagen is everywhere, right? It is a connective tissue in my blood vessels, in my joints, in my skin. So what is going to happen? There's going to be bleed because of the fragile blood vessels. So gum bleeding would be seen. In skin, you will see the corkscrew hair and the perifollicular redness. In joints, you see this classical subperiosteal hemorrhage and classical signs. This is the x-ray that the examiner is going to throw at you. Look at this x-ray. What are the signs that you can appreciate? This is the periosteum. Beneath the periosteum, can you see this area, black area? This is nothing but bleed. So there is subperiosteal hemorrhage. Look at the joint. The epiphysis is ring-like, right? Circular. This is known as ring epiphysis or Wimberger's ring. Then you have this line is known as provisional line of calcification or white line of Frankel. Just beneath this white line of Frankel, there is a black zone. This is known as scorbutic zone or Tremorfeld zone. And at the edge of this white line, these spurs are known as Pelton spur. So what are signs are you appreciating over here? Subperiosteal hemorrhage, epiphyseal ring or ring epiphysis, Wimberger ring, white line of Frankel, Pelton spur, and scorbutic zone or Tremorfeld zone. And look at the cortex. The cortex is so thin. The bone cortex is very thin. This is known as pencil thin cortex. Pencil thin cortex. Right? So all of these signs you appreciate in cases of scurvy. Now with that, now let's finally move to the fat soluble vitamins. And fat soluble, firstly, let's talk about vitamin A. So what does this vitamin A deficiency causes? This vitamin A deficiency causes night blindness, right? And skin, this is appreciated as dryness of the skin, phrinoderma, toad-like skin. And in eyes, you see night blindness. They ask, what is the first symptom and what is the first sign that you appreciate? Remember, the symptom is something that the patient presents to you with, and sign is something that you pick. So what is the first symptom? What is the first complaint from the patient end? It is going to be night blindness, that I am not able to see at night, night blindness. And what is the sign that you are going to pick? The first sign that you are going to pick is the dryness of the conjunctiva, right? So conjunctival xerosis is the first sign. Now let's look at the classification. Firstly, we have XN, that is the night blindness. We have X1. In X1, we have X1A and B. X1A is your conjunctival xerosis. B is appearance of this bite dot spot. Can you look in this picture? Can you see this heap of epithelial tissue over here. What is this? Bite dot spot. Then we have X2. In X2, now cornea will begin to dry. So there is corneal cirrhosis. Then we have X3. In X3 now, this dried cornea will ulcerate. So you will have corneal ulceration. If this corneal ulceration involves less than 1/3 of the surface area, then it is X3A. And in X3B, it will be more than 1/3 of the surface area, right? Then we have XS and XF. XS denotes scarring and F indicates your fundal changes, So this WHO classification is very important. This you must have studied in opthal also, right? So very important, staging WHO classification of vitamin A deficiency. And what is the first symptom? What is the first sign? This image of bite dot spot. Right? With that, now let's move to the next fat soluble vitamin, that is vitamin D. And we all know, what does this vitamin deficiency in growing bones cause? It causes rickets. And what about the grown bones like you and me? If we have vitamin D deficiency, what is going to happen? Osteomalacia is going to happen, right? In rickets, they ask the clinical features. What is the first sign that you appreciate in vitamin D deficiency or rickets? The first sign is craniotabes. Right? Ping pong skull, very soft skull, ping pong skull. Then comes the chest. You see a pigeon-shaped chest, right? Pectus carinatum, pigeon-shaped chest. Also, you see beading. What is that? Rachitic rosary. Painless round beading around the costochondral junctions. This is rachitic rosary. In lower limbs, you see bowing of legs. If you see that the knees touch each other, this is known as genu valgum. Remember, gum means something that is sticking, right? So if the knees are sticking, knees are joining in the middle, this is valgum. And when you see that the knees are falling apart, when you drink a lot of rum, you lie down on the floor or the bed like that, right? So if the knees are apart, this is genu varum, right? So remember, rum, knees apart, gum, knees together, right? And what if both knees go in one direction, either left or right? It looks like as if my knees are swept by wind, right? So this is known as wind-swept deformity. You can see any one of the following in the lower limbs, right? Bowing of legs, it could be genu valgum, genu varum, or wind-swept deformity, right? Knock knees. Now let's look at the X-ray feature. We discussed about the X-ray in cases of scurvy. Now let's look at the X-ray features in cases of rickets. Look at the bone right here. Can you see the hollowing, the cupping? This is known as cupping. And also there is widening around the joint area, which is known as splaying. And if you closely look at the end, there is fraying, right? So these three features, cupping, splaying, fraying. And also you can see the bones don't look that white, right? They look very hollow. This is decrease in the density of the bone. Right? So these are the features, X-ray features of rickets. Now let's look at the lab investigations that you will see over here. Right, so what is happening in rickets? My vitamin D is deficient. So why vitamin D is important for us? Because vitamin D is the only thing that helps me in the absorption of calcium and phosphate and helps in this deposition of calcium and phosphate into my bones. So it is helping the mineralization of bones. So what will happen if vitamin D is deficient? What will happen to my calcium? My calcium would be low, my phosphate will be low. And what happens when the calcium is low in my body? Then there are small glands around my thyroid, parathyroid glands. These parathyroid gland sense the low calcium by calcium sensing receptors and secrete parathyroid hormone. So in this case, parathyroid hormone will increase, right? Parathyroid hormone, what does this parathyroid hormone will do? This parathyroid hormone will try to increase the calcium in my body. How? By causing resorption from the bones. So this ALP would increase and there will be resorption of this calcium levels. So what are the lab investigation picture? Calcium could be low or normal, phosphate would be less, parathyroid hormone will increase, ALP will increase. They ask what is the most characteristic feature out of this. So remember, increase in the ALP is a very important marker over here. Right? Now let's talk about the treatment, how you're going to treat this rickets. There are two regimens, high dose regimen and low dose regimen. Which one do you follow? You prefer low dose regimen, right? What is the high dose regimen? In high dose regimen, we give 60,000 international units per week for 10 weeks. So total 6 lakh international units, right? So high dose is 60,000 international units per week. So we take either vitamin D shots or capsules of 60,000 IU and we take that for 10 weeks. So we say that every Sunday, we tell the parent every Sunday you give this one shot of vitamin D or one capsule of vitamin D and give that for 10 weeks. So total dose is going to be 6 lakh IU. And what about low dose regimen? Low dose regimen, every day you give vitamin D. 6,000 IU, every day we give this vitamin D. And this we give for 3 months. After completion of this regimen, we check the response to the treatment. What is the first response to the treatment? Response to the treatment would be appearance of white line of Frankel at the joint. White line of Frankel at the joint. This denotes that calcification has started, right? Deposition of calcium has started. So white line of Frankel is the first response to the treatment. With that, we cover vitamin D, rickets. Now let's move to vitamin E, tocopherol, right? So this vitamin E deficiency, what does this vitamin E deficiency causes? With the deficiency of vitamin E, you are going to see some of the hematological features, some of the neurological features. So what is the hematological feature that you notice in vitamin E deficiency? Hemolytic anemias, right? So here you're going to appreciate hemolytic anemia. And what about the neurological feature? Spinocerebellar ataxia. Spinocerebellar ataxia. Spinocerebellar ataxia. Right? Then comes vitamin K. Vitamin K, very important vitamin. Also, one of the vitamins that is deficient in breast milk. So, if we do not give this vitamin K injection at birth, what the neonate is going to have? The neonate is going to have hemorrhagic disease of newborn. Right? Bleeding tendencies would be there. With that, we complete important vitamins and their deficiencies. Now let's move to the very important topic of nutrition. Before going to nutrition, you should know what is malnutrition. Whenever we say malnutrition, it includes both the terms, undernutrition as well as overnutrition, right? But in India, overnutrition is still not a big problem. Undernutrition is. So whenever we are talking about malnutrition, think undernutrition only, right? So let's one by one look at these parameters and interpret the nutritional status of the child. Simple thumb rule is anything beyond plus minus 2 standard deviation is going to be abnormal. And anything beyond plus minus 3 standard deviation is going to be severely abnormal. Right? So for example, we studied short stature. Short stature means stunting. So if the child's height for the particular age is less than minus 2, then it is stunting. But when it becomes less than minus 3, it becomes severe stunting, right? So one by one, let's look into the parameters. Firstly, look at the first parameter, weight for height minus 2 to minus 3. That means this child's weight for that particular height, for his height, is abnormal. This is wasting, that the muscle or the weight is less for the particular height, wasting. This is going to be wasting or severe wasting. In between minus 2 to minus 3, this is wasting. If it is less than minus 3, it is going to be severe wasting. On the opposite end, if the child's weight is higher for the height, plus 2 to plus 3, this is going to be overweight child, overweight. and after +3 it is obese. Same goes for height for age. In between -2 to -3, this is stunting. When it is less than -3, it is going to be severe stunting, right? So this is how you interpret these different criteria and tell the nutritional status of this child, right? Now let's move to a very important concept of acute and chronic malnutrition. So what is acute malnutrition? So imagine a child, he got sick and had stopped eating food, right? So for a good whole week, the child did not eat much. So the child obviously is going to lose some weight during this course. But once he starts eating, he'll be back to normal. During this phase, the child's weight dropped down. But what do you think? What would have happened to his height? Would his height be also affected from the 7 days of illness? No, right? So this is what is acute malnutrition. The child's weight will drop, but height will stay normal. On the other hand, in chronic malnutrition, what happens? If the child is depleted of food for a long period of time, right? Maybe due to a prolonged illness, maybe due to some poverty issues, socioeconomic issues. If the child is deprived of nutrition, what will happen? Now, not only the weight but also the height would be affected. So remember, what will happen to the weight for age in acute malnutrition? It will be less. But what about height? It will be normal. If you take the ratio weight for height, weight is decreased, height is normal. So weight for height will be decreased. Now what about chronic malnutrition? Weight for age obviously would be less. Height for age again would be less. But what about the ratio? Weight is also decreased, height is also decreased. So weight for height may be normal over here, may be normal over here. So with this table comes 3 important MCQs. Which of these factor is common to both acute and chronic malnutrition? You can appreciate which factor is common. Weight for age is common. Then they ask which factor is the best marker for acute malnutrition. Weight for height is the best marker for acute malnutrition. Then they ask which marker is better for chronic malnutrition. It is the height for age, right? So remember these 3 MCQs. Common to both acute and chronic malnutrition is weight for age. Best marker for acute is weight for height, and best marker for chronic malnutrition is height for age. Height for age, right? With that, now let's move to the severe forms of malnutrition, right? This is the extreme forms or severe forms of malnutrition. Look at this child A, right? Very cachectic child, skin and bones baby, skin and bones baby. Very cachectic looking. It looks like as if this child has no fat. On the other hand, this child B, lying down listlessly, very lethargic, looks very chubby. This is known as fat sugar baby. Both of these are chronically malnourished children. Look at the child A. He's very alert looking. If I offer food to this child will very eagerly eat all that food. If a normal child of his age group eats 1 chapati, he's going to eat 4 chapatis, 5 chapatis, very voracious appetite. On the other hand, this child B, you can see he's lying down listlessly on the bed. If I offer food to this child won't have food, his appetite is lost. What do you think out of these is going to have a better prognosis? Obviously, A child is going to have better prognosis. He has preserved appetite. He can eat food and gain muscle, gain fat. But on the other hand, child B is not having food. His appetite is lost. He has swelled up, right? So poor prognosis in cases of child B. Child A is my marasmus child who has very well adapted to this malnutrition. On the other hand, B is your kwashiorkor child, which is maladapted to the situation, right? With that, now let's differentiate both of these. Firstly, marasmus. In marasmus, you saw how was the baby? Very cachexy looking. So wasting is appreciable, right? Wasting is very much visible. You have visible severe wasting. And what about the kwashiorkor baby? The kwashiorkor baby was also wasted, but because of the edema, that wasting was masked. So here, the wasting is masked. What about the general appearance and the status? So child A was very alert, sitting, है ना? So here the general status and appearance, the child would be very alert looking, and how the appearance is skin and bones baby. On the other hand, Kwashiorkor baby was very lethargic, very dull, fat sugar baby. Marasmus child had good appetite, in fact, voracious appetite. But the Kwashiorkor baby has lost the appetite, very low appetite. Age of onset marasmus can happen anytime, but Kwashiorkor usually happens after 1 year of age when suddenly the child consumes carb-rich and very low protein diets. Right? Prognosis here is going to be good. Here the prognosis is going to be poor. Right? Then we have certain skin and hair changes that we can see in both, but they are more pronounced in cases of Kwashiorkor. What are these skin and hair changes? We have flaky paint dermatosis, where there is peeling of skin as if the paint is flaking off the wall, chipping off the wall. Flaking paint dermatosis. You see flag sign in the hair, hypopigmentation and hyperpigmentation. And lastly, what do you see? You see crazy pavement appearance of the skin. Crazy pavement appearance. Crazy pavement appearance. You can see the skin and hair changes in both. Remember, here they are going to be more. Kwashiorkor, they are going to be more. And lastly, liver. What about liver? You see fatty liver in cases of Kwashiorkor and shrunken liver in cases of marasmus. Right, so this was about your extreme forms of malnutrition, marasmus, and Kwashiorkor. Now let's move to a very important topic, SAM. Definition of the SAM is something that you cannot miss out on. So what is the definition of the criteria for SAM? Remember, anyone, you need anyone, I need anyone. Only one thing to label it as SAM. First, weight for height less than -3 standard deviation. That is, there should be severe wasting. Severe wasting. Second is MUAC. Obviously, you will apply this MUAC in 6 months to 5 years of age. MUAC less than 11.5 centimeter. And lastly, there will be nutritional edema. Nutritional edema. Right? So this is SAM, definition or criteria of the SAM. With that, we cover the general pediatrics module. Now let's move to genetics. So in genetics, we are going to discuss some of the important genetic syndromes that the examiners are fond of asking. One of these is the most common encountered chromosomal anomaly, that is Down syndrome. So we all know what is Down syndrome. Down syndrome is trisomy 21. We have one additional 21st chromosome. What are the classical features of this Down syndrome? This picture tell you. What is this baby? What is this baby? This baby has typical down faces. What do I mean by down faces? Down faces are essentially flat faces, as if someone has flattened out the face, right? And also look at the eyes. The eyes are slanting like this. Eyes are slanting like this. That is, the outer canthi of the eye is going up as compared to the inner canthi. This is known as mongoloid slant. Mongoloid slant. Also, you have an eye fold. This is known as an epicanthal fold. Nose is flattened, mouth is open, protruding tongue is there. Also, you can see thickened, redundant skin over the back of the neck, very small ear, flat facial profile. All of these are features of Down syndrome. Also, look at this hand. Can you see a single horizontal crease? This is known as simian crease. Similarly, if you look at the foot of this child, what do you appreciate? That the great toe is separated like this from other toes, as if there has to be a sandal in between. So this is known as sandal gap. This is sandal gap. Right? So these are some of the phenotypic things that you are going to notice in Down syndrome. What about other features? The cardiovascular features, neurological features. These Down syndrome patients are prone to some cardiac anomalies, some of the renal anomalies, some of the gut anomalies. So let us look at these anomalies system-wise. Right? So there are certain associations. When we talk about the cardiovascular system, then the most commonly encounter congenital heart defects here is going to be endocardial cushion defects. Endocardial cushion defects. In GIT, you have annular pancreas, duodenal atresia, annular pancreas. Hematological, they're more prone to leukemias. What type of leukemias? ALL more than AML. And amongst AML, it is the M7 that you appreciate. Endocrine, they have congenital hypothyroidism predisposition. In skeleton, there are chances of atlantoaxial dislocations. That's why screening by neck x-ray is very important, especially after the age of 4 years. Atlantoaxial dislocations. And when we talk about neurological problems, then most of these children are mentally retarded, right? Their mental retardation is actually universal in cases of Down syndrome. Okay, so you can see how many problems are there associated with Down syndrome. So it is very important that you do antenatal screening and get an informed decision from the parents whether they want to continue this pregnancy or not, right? So it's very important that you go for antenatal screening. Some screening we do in the first trimester, some screening we do in the second trimester. We are going to look at the first trimester screening. In first trimester screening, you can do some blood test and also you can go for ultrasound. In ultrasound, what do I look for? In ultrasound, I look for nuchal thickness or nuchal translucency. If it is more than 3 mm, it is indicative of Down syndrome, right? And also we do a blood test in the mother, that is known as dual test. Two things I am going to check. I am going to check beta HCG and PAP-A. Beta HCG and PAP-A. If beta HCG is high, PAP-A is low, this is again indicative towards Down syndrome. Now let's move to the second trimester. In second trimester, we do triple test and quadruple test. In triple test, 3 markers again we are going to do: beta HCG, unconjugated estriol, and alpha fetoprotein. Remember, high again beta HCG and low of unconjugated estriol and alpha fetoprotein. In quadruple test, we do all the things of the triple test and add inhibin also. Which marker increases or decreases in Down syndrome? A very simple mnemonic to remember. Remember beta HCG and inhibin. H for high, I for increase. So these two only increase, rest all fall. Right? So very simple mnemonic for Down syndrome. So this is all about your Down syndrome and important markers, antenatal screening things, what are the associations. Now let's move to yet another important syndrome, that is Turner syndrome. So Turner syndrome is often confused with Noonan syndrome, which is also labeled as male Turner. But remember, Noonan is not male Turner, it's definitely a different set of disorder. What happens in Turner syndrome? We have monosomy XO. That means I have one chromosome less, XO. But what happens in Noonan syndrome? It is a genetic problem, a gene problem, right? PTPN11 gene problem. So here the chromosome number is fine. Some genetic problem is there. So definitely both of the disorders are different. One is the problem of chromosome number and other is a genetic problem, right? Here, because we don't have any Y chromosome, we have only one X chromosome. These are going to be girls only. But here the chromosome number is fine. This can be boy also. This can be a girl also. If you talk about IQ, in the Turner syndrome, girls have normal IQ. But their gonads are dysfunction. They have streak ovaries. Amenorrhea, streak ovaries. Right? So I remember it that way, that they are intelligent but they cannot have sex. Right? They can have sex obviously, but they cannot reproduce. So normal intelligent but cannot reproduce. On the other hand, Noonan syndrome, they have low IQ, but their gonads are normal. Right? No gonadal issue per se. Then comes the associations, cardiac associations and renal associations. We all know left-sided brain is very important for our intelligence, right? Left-sided has mainly your reasoning and everything. Right is for creativity. So here they have normal intelligence, left-sided. So they have left-sided heart anomalies. What is on our left side? We have left atrium, left ventricle, aorta. So they have bicuspid aortic valve and coarctation of aorta. On the other hand, here you are going to have right-sided problem. On the right side, you have right atrium, right ventricle, pulmonary artery, right? So you have pulmonary stenosis over here. So this is all about Turner and Noonan. Now let's briefly go through the features of the Turner syndrome. Short stature is going to be there, low hairline, droopy eyelids, low set ears, typical shield, widely spaced nipples, also known as shield chest. You have congenital heart diseases like we discussed, bicuspid aortic valve, coarctation of aorta. Renal anomalies are going to be there, streak ovaries are there, going to be there, very increased carrying angle, elbow deformities seen, brown spots, some nevi, knee deformities. All of these things are associated with Turner syndrome. Now let's move to yet another microdeletion syndrome, that is DiGeorge syndrome. In DiGeorge syndrome, we all know which chromosome is affected. Chromosome 22q11. Right? Here the third and the fourth pharyngeal defect is there. Third and the fourth pharyngeal arch defect. This third and fourth pharyngeal arch is very important for the development of thymus, for the development of my heart, for the development of my palate and everything. So what are the features you are going to appreciate over here? The mnemonic is catch-22. C is for the cardiac anomalies. The most common cardiac anomaly that you see over here is, most common cardiac anomaly that you see in DiGeorge syndrome is conotruncal defects like TOF, right? So conotruncal defects. Then A is for abnormal facies. T is for thymus. There is going to be thymic aplasia. C is for cleft palate, cleft lip, cleft palate. This H is for hypocalcemia. And this 22 is nothing but your 22 deletion, 22q11 deletion, microdeletion syndrome. Right? Okay. So with that, we cover the genetic section. Now let's move to neonatology. Neonatology, very important segment for INICT, especially the neonatal resuscitation protocol. So don't forget to revise that before your exams, right? So firstly, we are going to discuss some of the respiratory disorders that we encounter in cases of neonates. So broad thumb rule, if it is a preterm, most common respiratory disorder that you're going to see is respiratory distress syndrome or hyaline membrane disease. If it is a term baby born via cesarean section, the most common respiratory distress syndrome that you're going to see over here is transient tachypnea of newborn. And in post-term babies or babies who have faced some sort of in utero stress, they're going to have this meconium aspiration syndrome. So firstly, let's start with respiratory distress syndrome or hyaline membrane disease. It is caused, what is the cause over here? It happens in preterms because of the deficiency of mature surfactant. Because of the deficiency of mature surfactant, what happens? My alveoli will collapse because there is increase in the surface tension. So how will the X-ray appear? The X-ray will appear as white out lung or ground glass appearance. Ground glass appearance, right? And secondly, you will appreciate air bronchogram over here, air bronchogram. How can we prevent this? We can prevent this by giving antenatal steroids to the mother, and the treatment here is CPAP therapy. If CPAP therapy fails, then we give surfactant. What is the technique by which surfactant is given? The technique is INSURE technique. INSURE technique. What is this? Intubate, give surfactant, and extubate. INSURE technique. Right? Then comes the second entity, that is transient tachypnea of newborn. I told you why this happens. This happens in a term baby who is born by a cesarean section. So normally when the delivery happens through the vagina, what happens? My baby slides through a very narrow vaginal canal. Normally in utero, my lungs are filled up with fluid, and during this vaginal delivery, what happens? This fluid is expelled out through mouth and nose, and the lungs are clear. But when we take out the baby through a cesarean section procedure, then the baby is not going through that narrow vaginal canal. Some of the fluid gets retained into the lungs, right? So because of this retention of fluid in the lung, the baby has this transient tachypnea. How do you see that on X-ray? There will be infiltration. This infiltration of this fluid in the lungs gives a sunburst appearance. And also you can see this fluid in the interlobar fissure. So fluid in the interlobar fissure. What is the treatment over here? This is a transient condition. Sooner or later, this fluid will be resorbed. So here, just supportive treatment is to be given. This is a transient condition, not more than 72 hours. This is going to be there. Then we have meconium aspiration syndrome. What does this meconium do? This meconium can block my alveoli. This meconium can block the airway leading to the alveoli, completely block one airway. And what will happen to that segment? There will be collapse, segmental collapse. Also, this can be a partial blockage leading to a ball valve effect and hyperinflation on one side. And pneumonitis picture you will see. So these are the features. Again, supportive treatment is given over here. So now let's look at these x-rays and by one tell me which one is what. So image A, what can you see? White lung, white out lung, ground glass appearance, and also can you see the big airways delineating out? This is bronchogram, air bronchogram. This is the typical X-ray of RDS, respiratory distress syndrome, or hyaline membrane disease. Look at the image B. White arrow is pointing towards fluid that is accumulated in the horizontal fissure. This is transient tachypnea of newborn. Also, can you see the infiltrations around the hilum? This is sunburst appearance. Then we have the last picture where I can see one segment has collapsed and overall hyperinflated picture is there. This is meconium aspiration syndrome. Right? Dharmesh is correct. RDS, TTNB and MAS. ABC. Right? Now let's move to the scores. Important scores. I people very favorite this score, Silverman-Anderson score. They will give you a newborn, and every time they give the same question, the answer to that question is 8. But definitely you should know the scoring system, because someday they might give some different question here and there, and the answer might change. So let's understand these respiratory distress score. So what this score is going to tell me? This score is going to tell me how much is the level of distress. More the score, more the distress. So it will help me to tell whether this child is in severe distress, mild distress, moderate distress. Should I ventilate this child? Should I intubate this child? Should I give CPAP therapy? Should I just wait and watch? Right? So more the score, severe the distress. So we have two scores in newborn for respiratory distress: Silverman-Anderson score and Downey score. Silverman-Anderson score, it is a big name. This big name is for a small child. That means this score I am going to use for preterms. So for preterms, we apply the Silverman-Anderson score. 5 components: upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring, and grunting. Lower chest and xiphoid retractions and nasal flaring, these 3 are very easy to remember. I told you that more the score, that means worse the distress. So if the lower chest retractions, xiphoid retractions, and nasal retractions are very mild, no nasal flaring, then it is 0. Sorry. If there is no chest retractions, no xiphoid retractions, no nasal flaring, it's 0. If it is mild retractions, mild flaring, 1. If it is moderate to severe, 2. Right? Then comes grunting. What is grunting? Expiration against the partially closed glottis. So at the time of expiration, a weird sound you are going to hear. Right? This grunting, if you are not hearing any grunting, 0. If this grunting is audible only via stethoscope, that means you cannot hear grunting per se, but once you place the stethoscope over the chest of the child, you are going to appreciate grunt. So if grunting is audible with stethoscope, this is 1. And if you don't need stethoscope, you are able to hear the grunt with your naked ear. Even mother can hear that the child is grunting. This is 2. So if the grunting is audible with naked ear, it's 2. Lastly comes upper chest retractions. Why I left this in the end? Understand when the child is breathing. If you look at the child, a newborn lying down breathing, the breathing is synchronous. That the chest will move and the abdomen will follow. This is synchronous breathing. But if the child is in distress, the child will be breathing fast. So initially you will appreciate that there is certain lag on inspiration because of this fast breathing. And at one point when the distress becomes too severe, you will appreciate seesaw movement, seesaw breathing. So initially if there is synchronous breathing, 0. If there is a lag on inspiration, 1. If there is seesaw movement that you appreciate, 2. Right? So this is the Silverman-Anderson score. Now let's move to Downey score. I told you Silverman-Anderson score, big name for a small child, preterm child. Downey score is for a term child. Here the mnemonic to remember the components of Downey score is GRACE. In one of your exams, INSET exam, they asked which of these components is not a part of Downey score. And different things were given. And out of these, one was color, something like that. Right? So remember what are the components? G is for grunting. R is for respiratory rate. A is for air entry. C is for cyanosis. And R is for retractions. So grunting is similar to the Silverman-Anderson score. No grunting, 0. Audible with stethoscope, 1. Audible with naked ear, 2. Retractions is also same. No retractions, 0. Mild, 1. Moderate to severe, 2. Then comes respiratory rate. The normal respiratory rate of a newborn is 40 to 60. So if the respiratory rate is less than 60, 0. If it is 60 to 80, 1. If it is above 80, it's 2. Right? Then comes air entry. If the air entry is normal, equal air entry on both the sides, 0. If the air entry is decreased, 1. If the air entry is absent, 2. Then comes cyanosis. If there is no cyanosis, 0. If there is cyanosis on room air and you apply oxygen and the cyanosis disappears, it's 1. So if there is cyanosis on room air, it's 1. If even after giving 30% oxygen, the cyanosis is still there, it's 2. So if there is cyanosis on 30% oxygen, it's 2. Right, so this is Downey score. Remember the components are very important. GRACE is the mnemonic, grunting, respiratory rate, air entry, cyanosis, and retractions. Okay, so now that we are talking about scores, let's talk about this other score. This score we all are given, the very first score that we are given after birth. Right? What is this score? APGAR score. This was named after the Dr. APGAR who actually gave the score. But we are going to remember this APGAR score by its name only, right? Its name, APGAR, is its mnemonic. A is for appearance. P is pulse rate or heart rate. G is for grimace. A is activity. And what is R? R is the respiratory efforts. So firstly, appearance. If the baby is appearing blue to you, you give 0. If the baby appears, if the baby appears blue to you, you give 0. If the baby's extremities are blue, that means hands or feet are blue, but the trunk, the body is pink, we give it 1. If the baby is fully pink, you give it 2. Right? So here, more the score, better the baby is. Then we have pulse rate, heart rate. If there is no heart rate, 0. If the heart rate is there but less than 100, 1. More than 100, 2. Then we have grimace response. How do we elicit grimace response? By suction. If there is no response, 0. If the grimace response is there, then 1. And if the baby sneezes or cough out, then 2. Activity wise, if the baby is limp, 0. If there is some flexion, 1. If good flexion, actively moving the limbs, 2. Then comes respiratory efforts. If no efforts, 0. If there is labored breathing, then 1. And if there is good cry, then 2. Right? So this is all about APGAR score. Yes, acrocyanosis is 1. Okay, so with that, now let's move to the next topic, that is neonatal sepsis. Neonatal sepsis. So when we talk about neonatal sepsis, what does the examiner ask first? What is the most common cause? Which organism, which bacteria is the most common cause of the sepsis? Remember, when we talk about India, the most common organism is Klebsiella. But worldwide, it's Streptococcus. Group B, Streptococcus. Group B, Streptococcus. Right? In neonatal sepsis, we have two categories of sepsis: early onset neonatal sepsis and late onset neonatal sepsis. So what are the risk factors for both of these? When we are talking about neonates, initially we discussed in the periods of growth that we have something that is known as early neonate and late neonate. Neonate is someone who is in the first 28 days of life. Early neonate is first 7 days, and late neonate is after 7 days till 28 days. But this is early onset. So this is not, don't confuse it with first 7 days of life, right? Early onset means if the infection is contracted within 72 hours of life. Within 72 hours of life, this is early onset, and after 72 hours, it is late onset. So early onset sepsis means within the 72 hours only the child contracted some infection. So that means this infection is from the mother itself. That's why this child has developed such early infection. So the risk factors for such early infections would be if the mother had prolonged labor, if the mother had prolonged rupture of membranes, if the child had spontaneous prematurity, if there is some sort of birth asphyxia, if there were multiple unsterile PVs who were done, right? So let's list down the risk factors. Firstly, it's prolonged labor. So if the labor is prolonged for more than 24 hours, if there is prolonged rupture of membranes, if there is spontaneous prematurity, if there is birth asphyxia, right? If multiple PVs were done, it is said that a single unsterile PV and 3 or more sterile PVs. Lastly, if the mother has some features of chorioamniotis, maternal fever, all of these is going to be a risk factor. What about late onset sepsis? This late onset neonatal sepsis happened after 72 hours of life. So it must be community acquired or hospital acquired. So the reasons would be unclean hands, poor hygiene, right? If the poor cord care is there, if the mother is not breastfeeding, there is bottle feeding, right? All of these are signs of risk factors for late onset sepsis. Now, how you are going to investigate? It is an infection, sepsis. So gold standard here is going to be blood culture only. So gold standard is blood culture, but we know this blood culture take 3 to 5 days to appear. So what you are going to do meanwhile? We are going to do the screen that is known as sepsis screen. So the sepsis screen has certain components, and if 2 or more abnormal components are there, we say that the screen is positive, right? So for the sepsis screen, remember, I need 2 or more abnormal values. If 2 or more abnormal values are there, the screen is positive then. So first component is absolute neutrophil count. If it is less than 1800, then it is abnormal. Then comes IT ratio, that is immature to total neutrophil ratio. Neutrophil ratio, right? If it is more than 20% or more than 0.2, it is considered abnormal. Then we have CRP. CRP more than 1 nanogram per ml. And lastly, we have micro ESR. If it is more than 15 mm per hour, it is abnormal. So I need 2 or more than 2 abnormal values out of these to label it as positive. Now let's understand the treatment. The treatment, because it is an infection, is going to be antibiotics only. We start with empirical antibiotics first. We give ampicillin plus gentamicin. If the child is not responding to these antibiotics for 48 hours, we move to third generation cephalosporins. And if the child has meningitis, then we start with the third generation cephalosporin only. We don't give this empirical ampi genta. The question comes, how much duration of antibiotics you have to give. So remember, if the sepsis screen is positive, then you give it for 7 days. If blood culture is positive, 14 days. If there is meningitis, 21 days. So remember, 1 week, 2 week, 3 week. Right? So this is all about neonatal sepsis. Now we are talking about neonatal sepsis. One sepsis, gut sepsis, that is necrotizing enterocolitis, deserves a mention. In NEC, what is happening? The name itself says, itis means inflammation. So there is inflammation of the colon and the small intestine, enterocolitis, right? Small intestine and the colon, and necrotizing inflammation is there, right? Necrosis is overall there. So we have staging, Bell staging, which the examiner is fond of asking. So what will happen over here? Firstly, I know there is inflammation of the gut. So what is the first feature that you're going to see? The child is going to be looking sick, lethargic, there will be feed intolerance, vomiting, there will be abdominal distension, there can be blood and stools. So stage 1 is divided into stage 1A and 1B depending upon this clinical feature only. In 1A, you will see occult blood and stools. Occult blood and stools. That means you won't see blood with the naked eye. You see that under the microscope. Under the microscope, you will notice these RBCs. And in stage 1B, you will see gross blood. That even mother will tell that in stools, doctor, there is blood. Here, no specific imaging feature is seen. Only the clinical features that the baby is sick, lethargic, there's going to be abdominal distension, feed intolerance, vomitings, right? And this blood and stools. Then comes stage 2. In stage 2, along with the features of stage 1, you will appreciate a classical triad. This is known as a metabolic triad. What do you see in this metabolic triad? In this metabolic triad, I will see metabolic acidosis. You will see hyponatremia and thrombocytopenia. That means low platelets. And now you will appreciate certain imaging features. On the basis of imaging features, the stage 2 is divided into stage 2A and B. In A, what do you see? In A, you see that the air has gone and trapped in between the layers of the intestine. This is known as pneumatosis intestinalis. Pneumatosis intestinalis. And in stage 2B, you see air trapped in between the portal vein. So this is known as pneumatosis portalis. Now in stage 3, full-blown perforation has happened. So in clinical feature, you will notice peritonitis-like features, which is stage 3A. And then in 3B, you will see the imaging feature, that is pneumoperitoneum, air under the diaphragm. Right? So remember stage 1A, 1B on the basis of clinical feature, that is presence of blood in the stools. If occult blood, 1A. If gross blood, 1B. Stage 2 is divided into 2A and 2B on the basis of imaging feature, not clinical, imaging feature. Pneumatosis intestinalis, 2A, portalis, 2B. And stage 3, 3A is clinical feature, that is peritonitis, and stage 3B is pneumoperitoneum. Right? So this is about the Bell staging, very important for your exam. Now let's start with a big topic of neonatal resuscitation, right? If one topic you have to study before your exam, especially the INI exam, every year they are going to throw one question, at least one question out of this segment, right? They will never ever forget this, right? If one question has to come from pediatrics, it will be from neonatal resuscitation. That's how important this is. So neonatal resuscitation protocol. So remember, these babies are born with good heart, and bad lungs. Good heart and bad lungs. What do I mean by good heart and bad lungs? That means whenever we are starting with the resuscitation, the focus is going to be lungs because they are bad, right? So my cornerstone of NRP is going to be effective ventilation. The cornerstone of NRP is effective ventilation. If despite this effective ventilation, the baby is not responding, if despite this effective ventilation, the baby is not responding, then I will go towards heart. Then I will choose chest compressions or epinephrine, right? So this is the cornerstone. So one by one, let's understand what we are going to do. Firstly, we have pre-birth questions. What are the pre-birth questions? 4 pre-birth questions. Whenever a baby is going to arrive into this world, your OBGYN friend will call you that please come and receive this baby. You're going to ask these 4 pre-birth questions. The first pre-birth question, whether this is a term baby or a preterm baby. That means I'm going to ask the gestation age of this baby, right? Secondly, I'm going to ask if there is any maternal risk factor. Maternal risk factor. That means if it is a high risk delivery or not. Then I'm going to ask whether there is meconium stained liquor or not. That means I'm going to ask the color of the amniotic fluid. And lastly, the cord management plan. Cord management plan means whenever the baby is delivered, I will discuss pre-hand with the OBGY that I am going to do delayed cord clamping or not. Cord management indicates my delayed cord clamping. That is, we will delay the cord clamping in most of the scenarios. If resuscitation is needed, we won't delay. But if everything is normal, we will delay the cord clamping for 60 seconds. 60 seconds. So this is the 4 pre-birth questions. Earlier, single baby or multiple baby was also included, but now that question is not there. Right? So after this pre-birth questions, we will start equipment check, assign our team members and prepare for the birth. Post-birth, 3 questions are there. What are the 3 questions? Term, tone, cry. Whether this baby is a term baby, is the tone good? Did the baby cry well? If the answer to all of these questions is yes, then the baby needs routine care. If the answer to any of these questions is no, then I will go for initial steps of resuscitation. If the baby is not responding to this initial steps of resuscitation, that means even after the initial steps of resuscitation, if the heart rate of the baby is less than 100, then we start ventilation. Which was earlier called positive pressure ventilation. Now the recent update has come and this positive pressure ventilation is replaced by the term ventilation, right? So we start ventilation. After 30 seconds of this effective ventilation, if the heart rate is still less than 60, then I'm going to start chest compressions along with this ventilation. 1 minute, that means 60 seconds of this chest compression and effective ventilation. If the baby's heart rate is still less than 60, you're going to give epinephrine. And even after repeating this dose of epinephrine, if the baby is not responding, then you rule out 2 conditions: pneumothorax and shock, blood loss, right? For pneumothorax, you do thoracotomy, and for blood loss, you give volume expanders like normal saline. So one by one, we are going to cover this concept only by these one-liners. So first one-liner, what is the most important step in neonatal resuscitation? I told you, babies are born with good heart and bad lungs. So what is the most important step? most important step is effective ventilation. Effective ventilation. Then comes the golden 1 minute. What is the golden 1 minute? If the baby needs positive pressure ventilation, if the baby needs ventilation, it should be started within 60 seconds. This is the golden 1 minute, 60 seconds. Then comes the initial steps of resuscitation. If the baby term, tone, cry, if the question answer to any of these questions is no, you start this initial steps of resuscitation. What are these? Position, airway, dry, stimulate, pads. What is the position? Sniffing position. Do we do routine suctioning? No, routine suctioning is not done. Even if meconium is present, you don't do routine suctioning. Suctioning is done only when needed. No routine suctioning. Then when do you start positive pressure ventilation? When do you start ventilation? If the heart rate is less than 100 after your initial steps of resuscitation. When do you start chest compressions? If the heart rate is less than 60 after 30 seconds of positive pressure ventilation. How do you start chest compressions? What are the compression to ventilation ratio? The compression to ventilation ratio is 3:1. That means you compress 1, 2, 3 and then give one breath. 1, 2, 3, breath. 1, 2, 3, breath. Right? What is the site of this chest compression? The site of this chest compression is lower 1/3 of the sternum. Just below the level of nipples. And how deep should be the compressions? Compressions again would be 1/3 of the AP diameter of the chest. The best indicator of the effective ventilation is increase in the heart rate. Remember, this is a very favorite mnemonic. Which of these is the most important indicator of the effective ventilation? If you are doing effective ventilation, heart rate should increase. Then comes the concentration of oxygen. For term babies, you should start with 21%. For preterm babies, 21 to 30%. If the baby has labored breathing but heart rate is more than 100, then you give CPAP and positive pressure ventilation if needed. When do you start epinephrine? If the heart rate is still less than 60 after 60 seconds of compression and ventilation. What is the preferred route of giving epinephrine? Preferred route is your intravenous route through umbilical venous catheter. The dose that we use is 0.2 ml per kg. 0.2 ml per kg. This is of the concentration 1:10,000 dilution. If no IV access is there, then you use intraosseous route or endotracheal route. The volume expander that we use is normal saline. What is the indication of volume expansion? If there is a suspected bleed happening, right? So by this, we have covered most of the question. Then comes a very old concept of meconium stained lacquer babies. Earlier, these babies were divided into vigorous baby, non-vigorous baby. What is a vigorous baby? When the heart rate is more than 100, the activity is good. In these babies, nothing you have to do with routine care you have to do. Non-vigorous babies are those babies whose heart rate is less than 100 and activity is poor. In these babies, you have to follow your routine neonatal resuscitation protocol. No special thing has to be done. Remember, this delayed cord clamping is not done if the baby requires immediate resuscitation. If no resuscitation is required, then we delay the cord clamping for 60 seconds. Why we are delaying this cord clamping? Because this will allow some additional amount of blood to flow to the baby through the cord, and this decreases the chances of anemia in later life, right? Not right now, but in later life the chances of anemias would be less, right? With that, we end this NRP protocol, a very rapid fire thing. Now let's move on to a very important segment of congenital infections. Right, so congenital infections, 3 infections very important: toxoplasmosis, congenital rubella syndrome, and CMV infection. And all three things would be there. A triad like scenario would be there. Let's start with congenital toxoplasmosis. Firstly, you are going to see one eye sign. What is that eye sign? Chorioretinitis. Then you see certain calcification in the brain. What type of calcification? Diffuse calcification. And third is, yes, hydrocephalus. Head problem, hydrocephalus. Then comes congenital rubella syndrome. Firstly, you will see a heart problem. patent ductus arteriosus PDA, then an ear problem, sensory neural hearing loss, then you will see eye problem, that is cataract. Similarly for CMV, compare it to toxoplasma. Here also you will see C for chorioretinitis, M for microcephaly, small head, right? And V is for ventricle. So here I see ventricular calcification. Right, so compare it with toxoplasma. Chorioretinitis is common. In toxoplasma, diffuse calcification were there. Here you have periventricular calcification. In toxoplasmosis, big head hydrocephalus were there. In CMV, small head microcephaly is there. Right, so CMV is the mnemonic for congenital CMV infections. So with that, now let's move to important segment, GI system diarrheas. What is the most common cause of diarrhea in preterms? Is it bacterial or viral? It's bacterial or viral? It's viral, right? So viral diarrheas are more common as compared to bacterial diarrheas. That's why usually we don't give antibiotics for pediatric diarrheas, right? No antibiotic for the pediatric diarrheas. If I ask you what is the most common viral cause, it is the rotavirus. And what is the most common bacterial cause? The most common bacterial cause is E. coli. Which type of E. coli? Enterotoxicogenic E. coli. Right? And what about dysentery? What is dysentery? Loose stools with blood. The most common cause of dysentery is Shigella. So now let's talk about the management of diarrheas. As I told you, the viral diarrheas are more common in pediatric population as compared to the bacterial diarrheas. So here the management of diarrhea would be just managing the dehydration that is associated with this diarrhea and supplementation with zinc. So dehydration management and administration of zinc make the cornerstone of management of diarrhea. So let's understand the dehydration correction first. So whenever a child with diarrhea, loose stools, vomiting comes to you, firstly you assess the level of dehydration and then you manage accordingly. We have 3 levels of dehydration: no dehydration, some dehydration, and severe dehydration. No dehydration, the name itself tells that there is no dehydration. So that means this child would be an alert child, normal consciousness alert child. If you offer water to this child, this child has no dehydration. So this child will be drinking water normally, right? So normally gentle like the child, the thirst is normal, so the child will gently drink water. If you do skin pinch, the skin pinch recoil would be again normal, immediate recoil. Eyes would also look normal to you. Here I give plan A. Then comes some dehydration. Now some degree of dehydration has set in. So this child will be very irritable. If you offer water to this child will now very eagerly drink water. He will be very thirsty, right? So this child will eagerly drink water. Skin pinch here would be delayed, but less than 2 seconds. Eyes would look sunken. Oral mucosa would also be dry. Here I do plan B. Then comes lastly severe dehydration. Here the child is now severely dehydrated. So the child would look comatose, lethargic. If you offer water to this child, will this child be able to drink water? No, he's lying comatose, lethargic. So this child will be unable to drink water, unable to drink. Here the skin pinch is very delayed, more than 2 seconds. Eyes look very sunken, oral mucosa is very dry. Here I go for plan C. Right, so one by one, let's understand plan A, plan B, plan C. So plan A was for a child who had no dehydration, just losses through the stool or vomiting is happening, and the child does not have dehydration per se now. The child can very easily drink water through his mouth. So here, the rehydration solution that I am going to give is oral plan ORS, oral rehydration solution. How much? 10 ml per kg per loose stool. Right, so for every loose stool the mother has to give 10 ml per kg of fluid to drink. So if it is a 10 kg child, for every loose stool, 100 ml of ORS has to be consumed. Then comes plan B. Plan B, the child has some dehydration. So though this child can take orally, but this child has some level of dehydration. So firstly, I have to rehydrate the child. Alongside, I have to replace the losses of the child. Right? So here again, the child can drink. So I will give oral ORS. Firstly, you have to rehydrate 75 ml per kg over the next 4 hours. Replacement of losses will stay the same. And again, in all of these, you have to ensure that maintenance fluids that we all require every day are covered. In plan C, when the child has severe dehydration, now the child cannot take orally, so I will give IV. The fluid of choice here is Ringer lactate. Rehydration here is given as 100 ml per kg. If it is a small child less than 1 year, then I give initial 30 ml per kg over 1 hour, rest 70 ml per kg over 5 hours. And if it is a big child above 1 year, then this can be given faster. Over 30 minutes I give this, and over 2.5 hours I give this. Other replacement of the losses and maintenance fluids stay the same. Let's understand the concept of maintenance fluid. So we all know that we need water. So you and me, everyone, we need some amount of water for our day-to-day activity, right? This is known as maintenance fluid. This is the bare minimum that you and me, everyone requires. How do we calculate this? By holiday cigar method. For the first 10 kgs, it is 100 ml per kg. For the next 10 kg, that is from 10 kg to 11 to 20 kg, it's 50 ml per kg. And thereafter, for every subsequent kg, it is 20 ml per kg. So if I say calculate the maintenance fluid requirement for a 22 kg bacha, how will you calculate? For the first 10 kg, it's 100 ml per kg, so that would be 1000 ml. Then for the next 10 kg, it's 50 ml per kg, so it would be 500 ml. And for subsequent 2 kgs, it would be 2 into 20, that is 40 ml. So total maintenance fluid requirement would be 1540 ml for a 22 kg child. Right? So Dharmesh, Dhanush, absolutely correct. Right? So now let's move to the next important topic, that is pneumonia. In pneumonias, we have IMNCI guidelines. Before we go into the guidelines, we need to get our basics straight, right? First basic, what is fast breathing? Fast breathing, we have cut off as compared to the age. So remember, less than 2 months, if the respiratory rate is more than 60 breaths per minute, it's fast. After that, more than 50. After 12 months, more than 40. So remember 60, 50, 40, 2 months, 2 to 12 months, after 12 months. This is the criteria for fast breathing. Then we have danger signs. If any of these danger signs is there, the child is going to have severe pneumonia, you need to refer this patient further. Right? So what are the danger signs? If there is stridor in a calm child, this is a danger sign. If there is severe respiratory distress, cyanosis. If the child is unable to drink water, if the child's consciousness is not normal, the child looks abnormally sleepy. If the child's saturation is less than 90%, if the child has convulsions or seizures, all of these are danger signs. So with that, let's move to our IMNCI guidelines. So IMNCI divides this pneumonia, upper respiratory distress features and everything into 3 categories: no pneumonia, pneumonia and severe pneumonia. No pneumonia means there is no pneumonia, just child has some upper respiratory infection. So here the child is going to have cold, cough-like features, URI-like features, right? No signs of respiratory distress, no retractions, no respiratory rate, no danger sign, right? So here nothing but supportive treatment has to be given. Then comes pneumonia. In pneumonia, either you are going to have fast breathing, that is increase in the respiratory rate, and or retractions, but no danger sign. So here, the child has pneumonia, but no danger sign is there. So you can give oral antibiotic to this child and treat the child on OPD basis and tell the mother or the caregiver about the danger sign and when to follow up back, right? So here you will give antibiotic, we give oral amoxicillin for 5 days and ask for follow up, explain danger signs. Then comes pneumonia, severe pneumonia. If any danger sign is there, it is severe pneumonia. Here you give one shot of antibiotic. Usually we give ampicillin, gentamicin and refer to the higher center. So you give IV ampicillin and gentamicin and refer to the higher center for further management. So this is all about IMNCI guidelines. With that, I want to discuss a very important topic for respiratory system, that is cystic fibrosis. This is very favorite of INI examiners. That's why we are going into detail of this particular topic. So we all know this is a genetic problem. What is the inheritance over here? The inheritance here is autosomal recessive. The gene is the CFTR gene that is defective. On which chromosome this gene is there? On chromosome number 7. The most common mutation is deletion of the phenylalanine at 508 position, right? And the protein defect is the CFTR protein only. This is a chloride channel. The common pathogens over here depend upon the age. In infancy and childhood, the common pathogen is the Staph aureus, and in adults it is Pseudomonas. Right, what are the features? You see pancreatic insufficiency, you see meconium ileus, rectal prolapse, liver involvement, male infertility. The gold standard test for diagnosis over here is the sweat chloride test, right? Sweat chloride test. What is the abnormal levels that you see over here? The abnormal levels are more than 60 millimole per liter in more than 2 separate tests. It is indicative. And obviously genetic testing detecting 2 CFTR mutations is yet another confirmatory test. There is no permanent cure yet. We do supportive therapies like Dornase alpha to liquefying the mucus, hypertonic salines, bronchodilators, antibiotics, pancreatic enzyme supplementation, and in pharma you'll be studying about the CFTR modulators, which is yet another important topic for your exam, right? Now, certain one-liners that are associated with this cystic fibrosis, they ask about the earliest GI manifestation that you see. Remember, the earliest GI manifestation is meconium ileus. The earliest pulmonary pathogen is Staph aureus. Most characteristic is Pseudomonas. And remember, the most deadly is Burkholderia capacia. Burkholderia capacia. Right? With that, now let's just discuss some more one-liners and examiner's favorite question. So examiner usually asks some of the associations of congenital heart disease with genetic syndromes. In genetics, we discussed about Down syndrome, Turner syndrome, Neonate syndrome and their associated CHTs. This table encapsulates all the commonly associated congenital heart disease in different genetic syndromes. So firstly, Down syndrome, we all know what is the most common. It's endocardial cushion defects. Endocardial cushion defect. Then in Turner syndrome, you see left-sided heart defects like bicuspid aortic valve, coarctation of aorta. In Noonan, right-sided problems like pulmonary stenosis. In Edward and Patau syndrome, you see ventricular septal defect. What is Edward syndrome? It's trisomy 18, E for Edward, E for 18. And what is Patau? It is trisomy 13. In Dijaw syndrome, we see conotruncal defects like TOF. And then we have Williams syndromes where you see supravalvular aortic stenosis. Supravalvular aortic stenosis. Then in certain maternal conditions, again you see association of congenital heart diseases. For example, in gestational diabetes, the most common congenital heart disease that we see is ventricular septal defect. And the most specific one is transposition of great arteries. We have rubella causing congenital rubella syndrome in the baby. And the common CHT we discussed is PDA. If the mother is an alcoholic, consumes alcohol throughout the pregnancy, the baby has chances of developing fetal alcohol syndrome. If the mother is taking phenytoin throughout the pregnancy, fetal Hydantoin syndrome. In both of these conditions, VSD is an important congenital heart disease that we encounter. If mother has bipolar disorder and is taking lithium, we see Epstein anomaly. If the mother has SLE and antero-antila antibodies, baby can have neonatal bradycardias, heart blocks, right? Heart blocks, neonatal bradycardia, right? With that, certain X-rays need a mention. So this first X-ray, what can you see? Figure of 8 appearance or snowman appearance. Where do you see this? We see this in TAPVC. Which TAPVC? Supracardiac TAPVC. Supracardiac TAPVC. Then we have this characteristic boat-shaped heart. Where do you see this? In tetralogy of Fallot. Tetralogy of Fallot. What are the 4 components of tetralogy of Fallot? We have pulmonary stenosis, ventricular septal defects, overriding aorta, and right ventricular hypertrophy. Then we have this box-shaped heart. Where do you see this? If the mother is consuming lithium for the bipolar disorder, right? So Epstein anomaly, box-shaped heart. Then we have this egg on string appearance. Where do you see this? In transposition of great arteries. Right? With that, we cover a very important segment of cardiovascular system. We will now fatafat wrap up the pediatric epilepsy syndromes and end the session. So in pediatric epilepsy syndrome, what is important? Age group is very important. The semiology or type of seizure that you are going to see is very important, and typical EEG finding. So West syndrome. The typical age group is before 1 year of age. You see characteristic triad. What is this triad? This triad will have one seizure finding, that is Salam spells or infantile spasms. You have one developmental finding, that is developmental regression. And you have one EEG finding, that is hips arrhythmia. Very chaotic pattern on the EEG, hips arrhythmia. The treatment is nothing but ACTH and steroids. So remember, if you look at Ghai, they have given drug of choice as ACTH or steroids. But as you are going to give INA exam, please prefer steroids, because in AIMS they give steroids. If this West syndrome is associated with tuberous sclerosis, the drug of choice changes to vigabatrin. Then we have Dravet syndrome. After 1 year, you see this, 1 to 2 years. Here, what do you see? Again, these 3 things. Seizure type, you see multiple seizures, different types of seizures, right? EEG finding will be typical. What is the EEG finding? An abnormal EEG study of these seizures. The drug of choice here is valproate. And the new drug over here is teripental. Okay. Then we have Lennox-Gastaut syndrome. This you see after 2 years of age. Here you will again see multiple types of seizures, developmental regression, and the EEG pattern typical over here is 2 to 3 spikes and wave complex. Drug of choice again here is going to be valproate. We have juvenile myoclonic epilepsy. Next, here the age group is adolescent females. The typical pattern here would be myoclonic jerks, shock-like contractions. And how they are triggered? Triggered by sleep deprivation and alcohol consumption. How do you see that on EEG? 4 to 6 polyspike wave complex. Drug of choice again valproate. The other alternative that you can use is levetiracetam. Lastly, absence seizures. Where do you see the school-going child? Brief episodes of vacant staring. Here the typical pattern is 3 hearts, spike and wave complex. Drug of choice here is ethosuximide. If ethosuximide is not in the option, choose valproate. With that, finally at 5 p.m. We are able to end this session. I hope this was helpful for your revision part and also to highlight all the segments that are important from the pediatric section. All the best for your exam. I will definitely meet after the exam with the recall session and would definitely want you to go through all of these topics, especially the neonatal resuscitation protocol before your exam. All the best. Thank you.